Hello, I'm Dr. Stephen Pipe from the University of Michigan. I work at the Hemophilia Treatment Center in Ann Arbor, Michigan in the USA, and I'm pleased to participate in this summation of the Hemophilia Guidelines from the World Federation of Hemophilia, the third edition that was just most recently published. This is accessible to all on the WFH website at the reference as it's listed here. I'm going to be going through the fifth chapter of the guidelines, which was focused on hemostatic agents. I'd like to take this opportunity to recognize the co-authors that worked with me on this panel. Manuel Carqueo, Kim Chu, Radek Kazmarek, Steve Kitchen, Johnny Malangu, Margaret Ozello, Ekawat Suantaraj, Jerzy Windiga, Glenn Pierce, and Alok Srivastava. These are my disclosures. So this is the state of hemostatic agents as they exist presently. There are different types of hemostatic agents, coagulation therapies available for the management of hemophilia. Clotting factor concentrates are the treatment of choice for people with hemophilia. There's two main types of so-called CFCs, virally inactivated plasma-derived products that are made from plasma donated by human blood donors, and then recombinant products that are manufactured using genetically engineered cells with recombinant technology. These two main types of clotting factor concentrates are the products of choice. We have recently seen the development of non-factor replacement therapies such as Emicizumab, which now offers an alternative treatment to traditional clotting factor concentrates. Now, where access to clotting factor concentrates and Emicizumab is limited, healthcare providers often still rely on locally produced blood products such as Cryoprecipitate and fresh frozen plasma for hemophilia treatment. Let's start with a clinical case. This is Liam, who's 9 months of age. He has severe hemophilia A. He was diagnosed at birth based on family history, a maternal uncle and grandfather who had been affected. He's had no factor VIII exposures to date, but he's starting to show more bruising and hematomas over his extremities now that he's started crawling. And the family's ready to consider initiating prophylactic factor VIII replacement therapy. Well, which product to start? Recombinant, plasma-derived clotting factor concentrates, or Emicizumab? Our first recommendation we're going to review is recommendation 5.1.1. And what we have laid out here is that for patients with hemophilia, the World Federation of Hemophilia does not express a preference for recombinant over plasma-derived factor concentrates. The choice between these classes of product must be made according to local criteria and would include availability, cost, and patient preferences. Some other aspects of product selection. Currently manufactured plasma-derived clotting factor concentrates are produced to good manufacturing practice standards and have an exemplary safety record with respect to lipid envelope viruses such as human immunodeficiency virus or HIV and hepatitis C virus. Product safety is the result of comprehensive measures and improvements in several areas, including donor selection, excluding at-risk donors, screening of donations, including nucleic acid testing, and a number of in-process viral inactivation and/or removal steps. Now, when selecting plasma-derived clotting factor concentrates, both plasma quality and the manufacturing process need to be considered. And there's two issues that require special consideration: the purity of the product and the form of viral inactivation and elimination. So our next recommendation is for people with hemophilia, the WFH recommends the use of products that have been accepted by the official regulatory agencies responsible for protecting and promoting public health, with consideration given to the plasma quality, that is, the purity of the product and the manufacturing process, and would include viral inactivation and elimination steps. The specific remark for this recommendation is that a plasma-derived product created by a process that incorporates two viral inactivation steps should not automatically be considered better than one that has only one specific viral inactivation step. If only one step is used, this step should preferably inactivate viruses with and without lipid envelopes. Most recently, lysis products do use two orthogonal viral inactivation or elimination steps. Our next case is James, who's 16 months of age. He also has severe hemophilia A. He was diagnosed at birth after bleeding from a circumcision, but he then presented at 4 months of age with intracranial hemorrhage and had to have a port central venous access device placed for regular infusions. He developed a high titer factor VIII inhibitor and had 1 year of an attempt at immune tolerance induction, but the inhibitor remained refractory. And the family is just not willing to continue the intense infusion schedule associated with this immune tolerance induction. So how should he be managed with now a refractory factor VIII inhibitor? Bypassing agents are used for the treatment and prevention of bleeding complications in patients with hemophilia A or B who develop factor VIII or factor IX alloantibodies. There's two primary bypassing agents. Recombinant activated factor VIIa promotes coagulation through a tissue factor dependent and independent pathways. Recombinant factor VIIa binds to tissue factor to activate factor X and factor IX and allows the coagulation cascade to resume even in the presence of inhibitors. The alternative product is activated prothrombin complex concentrates. These are used to treat patients with hemophilia A with inhibitors primarily. Activated prothrombin complex concentrates contain non-activated prothrombin, factor IX, factor X, and mainly activated factor VII. This recommendation states that the WFH recommends that patients with hemophilia with an inhibitor should be considered for regular prophylaxis to prevent bleeding events. And the drive behind this recommendation is we wanted to push to close the gap between the outcomes that are afforded to non-inhibitor patients who are on regular prophylaxis. And this should be, the same outcome should be able to be extended to those that are affected by inhibitors, including refractory inhibitors. Now, for patients with hemophilia A with an inhibitor, the WFH recommends that Emicizumab should be used for regular prophylaxis. For patients with hemophilia A with no inhibitor, the WFH recommends that Emicizumab can be used for regular prophylaxis. So what we're stating here is the evidence from the clinical trials and real-world use to date suggests that Emicizumab affords a more efficacious prophylactic benefit for patients with hemophilia with an inhibitor. It's early days in its application for non-inhibitor patients. The panel did not feel that there was really sufficient data to support that Emicizumab should be used for regular prophylaxis over traditional replacement factor VIII therapy, but it certainly can. And additionally, I want to point out to you that specific Emicizumab recommendations can be found across multiple other chapters as listed here. Our next clinical case is in the area of advocacy. So Henry is leading a national member organization, or NMO, for a country considered low to middle income. And the NMO is seeking to increase coverage of care for patients with hemophilia. Now, the initial outcome of interactions with their health authority have indicated that the health authority was only willing to support the use of locally produced fresh frozen plasma, or cryoprecipitate, for this population. Well, what are the current WFH recommendations regarding the use of fresh frozen plasma and cryoprecipitate for managing patients with hemophilia A? These fall under the category of other plasma products. Cryoprecipitate and FFP are not normally subjected to viral inactivation procedures such as heat or solvent detergent treatment, and consequently they carry an increased risk of transmission of viral pathogens, which is significant when patients are receiving repeated infusions. Certain steps can be taken to minimize the risk of transmission of viral pathogens. These include quarantining the plasma till the donor's been tested or even retested for antibodies to HIV, hepatitis C, and the surface antigens of the hepatitis B virus. And this is a practice that's difficult to implement in countries where the proportion of repeat donors is low. Nucleic acid testing, or NAT testing, to detect viruses is a technology that has potentially much greater relevance for the production of cryoprecipitate than for clotting factor concentrates, as the latter are already subjected to viral inactivation steps. So for this recommendation, for patients with hemophilia, the WFH strongly recommends the use of viral inactivated plasma-derived or recombinant clotting factor concentrates in preference to cryoprecipitate or fresh frozen plasma. Fresh frozen plasma contains all the coagulation factors, and it's sometimes used to treat coagulation factor deficiencies. Cryoprecipitate would be preferable to FFP for the treatment of hemophilia A. However, as FFP and cryopoor plasma contain factor IX, albeit in low concentrations, they can be used for the treatment of hemophilia B in countries who are just unable to afford plasma-derived factor IX clotting factor concentrates. Still, the recommendation here is for patients with hemophilia, fresh frozen plasma is not recommended due to concerns about the safety and quality. However, the WFH recognizes the as yet unavoidable reality of their continued use in some parts of the world where it is the only available or affordable treatment option. Cryoprecipitate is the insoluble concentrate of high molecular weight plasma proteins that precipitate when frozen plasma is slowly thawed coming out of deep freeze. Cryoprecipitate contains significant quantities of factor VIII, up to about 3 to as high as 10 units per ml. Also contains von Willebrand factor, fibrinogen, and factor 13, but not factor IX or factor 11. And the resultant supernatant is called cryopoor plasma and contains other coagulation factors such as factors 7, 9, 10, and 11. For this recommendation, patients with hemophilia, cryoprecipitate is not recommended due to concerns about the safety and quality. And the same principle here as we just stated, the use of cryoprecipitate can only be justified in situations where clotting factor concentrates are not available, as there's no proven advantage of their use over clotting factor concentrates. And it's strongly encouraged that viral inactivation procedures be used if available. What are some other pharmacological options that are addressed in this chapter? Well, in addition to clotting factor concentrates, other agents can be of great value in a significant proportion of cases and are often used as adjunctive therapies. We're going to talk about Desmopressin or DDAVP, Tranexamic Acid, and Epsilon aminocaproic acid. First, Desmopressin. This is a synthetic analog of vasopressin that boosts the plasma levels of factor VIII and von Willebrand factor. This may be the treatment of choice for patients with mild or moderate hemophilia A when and if factor VIII can be raised to an appropriate therapeutic level, because it avoids the expense and the potential hazards of using clotting factor concentrates, including the risk of factor VIII inhibitor development. Now, DDAVP does not affect factor IX levels and is of no value in hemophilia B. It's not licensed for use in pregnancy, but it has been used with caution in pregnant carriers during labor and delivery. A single dose of 0.3 micrograms per kilogram body weight, either via intravenous or subcutaneous administration, can be expected to boost the factor VIII level by up to 3 to even 6-fold over baseline. Now, children should generally not be given DDAVP more than once per day. In adults under close supervision, twice daily dosing may be considered. For patients with mild or moderate hemophilia A and carriers of hemophilia A, the WFH recommends considering Desmopressin as an option for treatment. And there's several important remarks here. The WFH recommends testing DDAVP prior to therapeutic use, a so-called DDAVP challenge. This is in order to evaluate the individual factor VIII response. And the decision to use DDAVP must be based on the patient's baseline factor VIII activity, the increment that's achieved post-dosing, and the duration of the treatment that's going to be required. In general, the most common adverse events observed are tachycardia, flushing, tremor, abdominal discomfort, and headache, especially during rapid infusions, and are mostly mild and transient. However, hypotension and even severe hyponatremia can also occur. For pregnant women during labor and delivery, the WFH recommends caution in the use of DDAVP, and it should be avoided in preeclampsia and eclampsia. With more than 3 consecutive days of dosing, the therapeutic response may decrease. This is called tachyphylaxis. And the risk of complications also rises. Thus, clotting factor concentrates may be needed when higher factor levels are required for a prolonged period. Tranexamic acid is an antifibrinolytic agent that competitively inhibits the activation of plasminogen to plasmin, and it promotes clot stability and is useful as adjunctive therapy for some types of hemophilic bleeding. Tranexamic acid alone is of no value in the prevention of hemarthroses in hemophilia. It's usually given as oral tablets at 25 milligrams per kilogram per dose, 3 to 4 times daily, but it can also be given by intravenous infusion at 10 milligrams per kilogram per dose, 2 to 3 times daily. And it's also available as an oral rinse. It is excreted by the kidneys, and the dose must be reduced if there's renal impairment in order to avoid toxic accumulation. It may be given alone or together with standard doses of clotting factor concentrates, including bypassing agents such as activated prothrombin complex concentrates and recombinant factor 7A. It is contraindicated in patients with hemophilia B who are receiving prothrombin complex concentrates as it increases the risk of thromboembolism. For patients with hemophilia, the WFH recommends that antifibrinolytics, which include tranexamic acid and aminocaproic acid, are a valuable alternative to use alone or as adjuvant treatment, particularly in controlling mucocutaneous bleeds. So here we're talking about epistaxis or nosebleeds, oral and gastrointestinal bleeding, and heavy menstrual bleeding or menorrhagia, as well as for dental surgery and eruption or shedding of teeth. The remark here is antifibrinolytics can be used with standard doses of clotting factor concentrates, including bypassing agents. However, they should not be used with prothrombin complex concentrates, primarily used for patients with hemophilia B due to an increased risk of thromboembolism. What about Epsilon aminocaproic acid, the other antifibrinolytic agent? It's similar to tranexamic acid, but it's less widely used as it has a shorter plasma half-life, a lower potency, and perhaps a higher toxicity. In adults, aminocaproic acid is typically administered orally at 100 milligrams per kilogram per dose, up to a maximum of 2 grams per dose, or intravenously at 100 milligrams per kilogram per dose, up to a maximum of 4 grams per dose, and can be given every 4 to 6 hours, up to a maximum of 24 grams per day. GI upset is a common complication with aminocaproic acid use, and reducing the dose often alleviates this side effect. Myopathy is a rare adverse reaction specifically reported in association with aminocaproic acid therapy. This has not been described with tranexamic acid. The myopathy associated with aminocaproic acid use is often painful and associated with elevated levels of creatinine kinase and maybe even myoglobinuria. Full resolution may be expected once aminocaproic acid treatment is stopped. What about new and emerging innovative therapies? Well, the first ones we can talk about are the non-factor replacement therapies. And these have been developed with alternative modes of delivery, example, subcutaneous delivery. They've been developed with targets that overcome the limitations of current clotting factor replacement therapy. Intravenous administration, short half-life, and risk of inhibitor formation, all of which are challenges with traditional clotting factor replacement therapy. And they also come with markedly improved pharmacokinetic profiles with a very low burden of administration, with some examples up to monthly or every 4-week dosing, all of which may increase compliance with continued prophylaxis with such agents. Emicizumab is the first in this category to be approved. It's a chimeric bispecific humanized antibody that's directed against the enzyme factor 11A and the zymogen factor 10 that mimics the cofactor function of factor 8 in patients with hemophilia A with or without inhibitors. The key benefits of emicizumab are its subcutaneous route of administration, long half-life, high efficacy in bleed prevention, and reduction of the frequency of bleeding episodes. Emicizumab is not intended to treat acute bleeding episodes. Here's our next case. This is William, who's 8 years old. He has severe hemophilia A. He's been on primary prophylaxis since infancy. He's currently using a standard half-life factor 8 product every other day. But despite an aggressive regimen, he still has occasional breakthrough bleeds, and the family's struggling with adherence to his infusion schedule. So the questions are, would he benefit from an extended half-life product? If so, what regimen would be used? How to evaluate how he's doing on this new product? And does it matter which extended half-life factor 8 we choose from? First recommendation in this section: for people with hemophilia A receiving factor 8 concentrates who would benefit from optimization of prophylaxis, as in our case, the World Federation of Hemophilia recommends individualized pharmacokinetic monitoring. Now, the remark here is that peak factor levels should be measured 15 to 30 minutes after the infusion to verify the response to the calculated dose. And the plasma half-life can be determined either via a full PK, which can involve 10 to 11 blood samplings taken over a period of 32 to 96 hours, or with limited sampling in combination with population PK estimates. For patients with hemophilia B receiving factor IX concentrates who would benefit from optimization prophylaxis, the WFH also recommends pharmacokinetic monitoring. Now, the panel in coming up with these recommendations recognizes the sizable work in recent years on the application of new clinical tools for advancing individualized pharmacokinetic monitoring, particularly through the aid of population PK tools, some of which now have regulatory approval. And their clinical utility supports their application for both hemophilia A and hemophilia B. Extended half-life products. The frequency of infusions using standard half-life clotting factor concentrates is associated with an increased burden of treatment and often leads to poor adherence to prophylaxis regimens. Extended half-life products were developed to address the need to try to reduce the treatment burden of prophylaxis and to maintain higher factor trough levels to improve bleed prevention. For patients with hemophilia A or B, there's no evidence for any clinical safety issues in persons with hemophilia to recommend a preference among the various mechanisms of action. These include pegylation, polyethylene glycol conjugation, FC fusion, or albumin fusion, all of which have been used to extend the half-life of factor concentrates. Now, this recommendation was a source of much discussion because of disparities in regulatory approval between some countries and also an absence of observations at a preclinical level that are consistent across all mechanisms of action. So the WFH recommendations on EHL products were structured accordingly. The emphasis was on the absence of clinical safety issues and not on preclinical observations from animal models with unclear implications. The WFH recognizes that evaluation of both clinical and preclinical observations of EHL products has led to some divergence in regulatory approval for some pegylated products, which has impacted their licensing for prophylaxis and pediatric application in some geographies. Regarding allergic reactions, these are, albeit rarely, observed for all infusion treatment products and have been observed with fusion proteins as well. And regarding anti-polyethylene glycol or PEG antibodies, there's no published evidence to support that these have clinical safety implications in patients with hemophilia. The panel also recognizes that extended half-life factors offer some distinct advantages to reduce the burden of the frequency of prophylaxis, but may also be used to maintain higher trough levels in order to optimize prophylaxis in specific patients. And the availability of population PK tools that include EHL factors can also assist this application. For this recommendation, patients with hemophilia who are transitioning from standard half-life factor concentrates to extended half-life would typically require decreased dose frequencies, but EHL products may also be used to maintain higher trough levels to optimize prophylaxis. Pharmacokinetic guided dosing, as per the recommendations we reviewed previously, provides for more individualized prophylaxis. So in conclusion, what are some of the themes that came out in this chapter? There were three areas that I want us to use to sum up today. First, areas of corroboration with prior guidelines from the WFH. These guidelines continue to strongly advocate for viral inactivated products as preferred over non-viral inactivated products. There's also corroboration that there is no preference for either plasma-derived or recombinant clotting factors. It's about availability, personal preference, and what patients can actually get that is going to be the best for that patient. The second theme is in the area of taking advantage of new clinical tools. The use of population PK models for both standard half-life and extended half-life products allows for unprecedented individualization of prophylaxis and really optimization of use. And as these are really precious resources, these are wonderful tools to help us to use these to achieve the best outcomes for patients possible. And the third theme are some remaining areas of controversy. WFH recognizes that in some low-income countries, they may still be reliant on fresh frozen plasma and cryoprecipitate, despite the recommendations we've talked about today. And in addition, we just reviewed that there are some controversies as it relates to the mechanism of action of some extended half-life factors, but we chose in this panel to emphasize the issues that are important for clinical safety as it pertains to their use. So I want to thank you for participating as I went through this chapter today, and thank you to the Hemophilia Alliance for their support in developing this presentation.